first of all, good morning. I'd like to welcome you all to this webinar series on living well with cancer. We are running this series out of the living room at the Chris O'Brien Lifehouse in Sydney, Australia. So that's the place where we provide supportive care and integrative oncology services to patients. And today I'm really pleased that we're being joined by Dr. Cindy Mack, who is the Director of Breast Services, also by Kate Bilton, who's a clinical nurse specialist, and of course, Professor Judith Lacey, who is the head of the department here at the Integrative Oncology and Supportive Care Service. So I think before we get started into the webinar, I'd like to maybe ask you each to quickly introduce yourselves and tell us a little bit about how you came to be working in the space of breast cancer. So I might start with Dr. Cindy Mack.
Hello everyone, I'm Cindy Mack and I'm a breast surgeon. I'll be quite frank, I didn't think I was going to be doing breast surgery when I started out training in surgery, but then I discovered that I get to meet all these lovely women and have these great conversations with them. And it's a very, very rewarding career. So I'm really pleased now that I made that decision to be a breast surgeon.
Fantastic. Thank you, Cindy. Okay, I think we might move on to Kate next.
Hi, everyone. So I'm a clinical nurse specialist at Lifehouse. I started my nursing career at RPA and then I moved into the oncology field when I started giving chemo. I gave chemo for, I think it was around 5 years, and I really enjoyed oncology, so I then did a master's in oncology nursing, and then I kind of felt like I just wanted to do more of a coordinator role and take on a specific tumour stream. So a job, I didn't really know which one I wanted. I was interested in all cancer, but then a position came up in the breast unit. So yeah, I went for that and I'm really glad I did because I really enjoy breast as a specialty and working with all the lovely women that we get to meet. So yeah.
Thank you, Kate. Judith?
Hi, I'm Judith Lacey and for the last 5 years or so, I've been working as the Director of Supportive Care and Integrative Oncology here at Chris O'Brien Lifehouse and involved in integrative oncology internationally as well. My background is in general medicine and then in palliative care, and I realised that actually we've come so far ahead in cancer care that we've really worked over the years of how to keep people living longer with cancer. And my passion is how you best keep them well. And with the changes in therapies, in particular our approach to breast cancer, it's a different disease from when I studied medicine in the 80s to where we are now. We have a personalised approach, we understand breast cancer better, and people are living longer with metastatic disease. And so the challenge is how you keep people living well from the time of diagnosis all the way through. You know, breast cancer for me is as a woman, I think it's a particularly confronting disease. It often hits people, and people are often diagnosed at the prime of their lives, which I think is probably in their 50s. I think for women, after having children, you suddenly start engaging more in the world, and to be diagnosed with breast cancer and having to take time off work or incorporate your breast cancer treatment with your work and family life can be challenging. So I'm interested in how best we can keep people well from the time of diagnosis. So I'm just passionate about how we can do that.
Great, thank you, Judith. So my name is Diana Nehrig. I'm part of the team at the Supportive Care and Integrative Oncology Department at the Chris O'Brien Lifehouse. And what I'll be doing today is facilitating a discussion between these three lovely ladies on all things breast cancer. So our topic for today is it's not all about boobs, it's caring for the whole person. So the way we'd like to do this is we'll have a chat. We've prepared a few questions that we think are of interest and important, and we'll be discussing that together, probably for the first 45 minutes or so. And I'd like to encourage everyone who's listening in on this, if you do have any questions, to please pop them in the Q&A. So that's the function that you see at the bottom of your Zoom screen, and just sort of type in your questions, and we'll spend the last 15 minutes or so looking at those questions and hopefully answering those for you. So I think I'd like to kick off with Dr. Cindy Mack. And yeah, the first question is really, what is the impact, in your opinion, Cindy, on a woman who receives a diagnosis of breast cancer? And what's the impact on the whole person?
Well, everybody is different. That's the first thing I will say. And for some people, it's just a little blip in the road of life. And they just get on with it. They contact us. They're like, just, can you take it out? I'll do whatever you need me to do, the end. And then for other people, and I probably would say this is for most people, it's a really significant event. It impacts on all parts of their lives. And I think a lot of how they respond to it is also very dependent on what stresses are occurring in their lives at that point in time. And it might be they've got elderly parents to care for, a child that's doing the HSC, some big holiday that they've saved up for years with a big family reunion plan. This is going to disrupt it all. Sometimes it's things like they have seen a parent or a loved one go through treatment for cancer, and they think that that's what's going to happen to them, and they're really traumatized or scarred by that. So it has a massive impact on them, and then on all the people that they care for as well, their partners, their children, their colleagues at work. It's a pretty big deal, and I think that everybody has a different reaction to it, and so it's really hard to predict how a person's going to approach it. So they'll come into the rooms, sit down, and I have people who are really straightforward, really just, I'll do whatever you need me to do. Sure, I'll cancel that. That's fine. And then the other people who are, well, you see, I have this really big board meeting on. Is it possible that we could move things around a little bit to accommodate that? People's lives have to go on. There's no doubt about it. And you have to work in a way that supports their cancer treatment, but also the rest of their lives, because cancer is just one component of it.
Yes, thank you, Cindy. So it really does depend, doesn't it, on where someone's at in their life, and what sort of other commitments and stresses might be going on for that person.
And it also depends on their perception of what cancer is.
Yeah.
So I have people who the word cancer is just terrible. It's devastating to them. They think they're going to die from this, and they come in with a small screen detected cancer with just absolute fear and terror. And then the other people who have perhaps seen a mother go through this and come out on the other side and seen that it's actually not as terrifying as they thought it was going to be. And they're a little bit more relaxed about it. So different cancers of different grades and sizes, where I would be a bit more anxious, the patient's less anxious. And then when you have a screen detected small low grade cancer, the patient comes in absolutely in pieces, when you think actually in the scheme of cancers, this is not a terrible one.
Yes, absolutely. Yeah, so it really depends on someone's potential previous experiences and what their perception is of the disease cancer.
And also, it's really important to read that. I think that when they step into your room and they're complete unknown to you at that time, you have to spend some time trying to get some feeling of what they are like, and what the people who come in to support them are like. And what the interaction between the patient and their supporting person is like. And these are all kind of little nuances that you have to pick up on the fly. Nobody ever teaches you how to do this in medical school.
Absolutely. Yes. So can you even say, are there some common concerns that ladies with breast cancer typically have when they come to see you before surgery?
I think one of the big ones is that everybody assumes it's going to be surgery first. And then if I tell them that it may not be surgery first, it might be chemotherapy, it really does throw them a little bit, and they can have to readjust their framework. And then there are all the typical things that a surgeon really should take the time to answer. I know not all of my colleagues do, but everybody wants to know not just about the operation, they want to know what happens after the operation. will I need chemo? Will I need radiotherapy? How long does it go on for? Does my hair fall out? You know, how frequently will I need my radiotherapy? What are the side effects of all of these things? And it's very easy sometimes for us as surgeons to say, I don't do that bit. You know, your medical oncologist or your radiation oncologist will tell you about that. But you are the first point of contact, and it's a really big discussion for them. They're sometimes naive about it. Sometimes they know too much because they've been on Dr. Google. So I think it is important for a surgeon to put it all into perspective. You may not be able to answer every question because that's not your specialty, but you know, good surgeons should have some idea of where the patient's headed, or be frank if they really can't tell where the patient's headed based on current pathology.
Right, right. Well, I think that's a really good point. Obviously, you know, it impacts different areas of life, and so you want to know not what maybe just the next couple of weeks look like, but what the next few months look like, and even beyond that. So I think that would be a good question for Kate. I'm just wondering how you, can you talk a little bit about your role as a breast CNC, sort of in the entire care for breast cancer patients? How does that fit in?
So my my role is a lot about support. So I'll usually meet the patient. I can meet them sort of at any point along their treatment path, but often it's towards the beginning. So a lot of what I do is education. And as Cindy was saying, you know, patients sort of, when they find out they've got cancer, they want to know everything. They don't want to know just, like some do want to know, just give me the next step and then we'll deal with the next step after that and so on. But a lot just, they need to see the whole picture. They need to, because they do have other things going on in their life, they need to plan. So they're not happy with just, you're going to go have an operation and you're going to stay in hospital a night and we'll deal with, you know, we'll deal with everything after that. And as Cindy was saying, not all the doctors have time to sit and actually explain all of that to the patient. So often that's my role. So I'm explaining, you know, what sort of cancer they have. Not every breast cancer is the same. And therefore not every treatment is the same, or the order of treatment. So they need to understand, you know, why did my auntie have her treatment this way and why is mine this way? So it's a lot about getting them to actually understand their particular biology of the disease and their personalised treatment. So that, I think a lot of what I do is education and that sort of support. The other thing is I'm a link between the patient and then their different members of their team, because there's not just one doctor that looks after a breast cancer patient. There's a few involved. So often the patient will come to me with an issue, and then I can liaise with the different doctors who need to know about what's going on. And then sometimes that leads to, you know, changes in their treatment plan or a delay of something. And along those lines as well, I'm often their first point of contact back to the hospital if they have a complication. So instead of them having to go through the emergency pathway, I can just fast track them back into the hospital. They can see me, and then if needed, I can escalate things. So patients find that reassuring to just have that person they can call if they're worried about something. And, you know, sometimes patients will just call me because they need me to look up when their next appointment is. So it can be something as little as that, or, you know, bigger things, overseeing, coordinating, timings of things. Also, what I do is when I meet a new patient, and again, as Cindy was saying, everyone's different. Everyone handles the news differently. Some patients very stoic and just they're pragmatic, they just want to get on with it, get back to life. Other patients, you just gauge they're going to need all the support that is possible. So I can make those referrals. So I'm a big referrer to counselling, so psycho-oncology, physio, and then, you know, any services in the living room that they might need, social worker. So yeah, just making sure those referrals are in place so we can best support the patient. Yeah, that's pretty much my role. I'm sort of all over the place in the hospital. Like I see patients after their surgery. I'll talk to them before their surgery. I see them in clinic when they ring up and have a problem. So yeah, it's a role that encompasses a lot, but I think it's a really important role to support the patient and make sure that they're getting the best care.
Yeah. Absolutely. So it sounds like you're the person that where sort of all the threads come together and you help the patient sort of navigate the different aspects of treatment, both the anti-cancer treatment and also the supportive treatments that are available for someone to get through the entire treatment, I guess, as best as possible.
Yeah, and just navigating, you know, some patients have never been to hospital before. So just navigating their way through the system.
Okay, great. Thank you, Kate.
Yeah.
Well, I think that leads quite well over to some of the things that we do in the living room with supportive care and integrative oncology services. So, Judith, you see a lot of women going through breast cancer treatment, either during treatment or post-treatment. And yeah, can you maybe talk to what sort of symptoms people typically seek the services in the living room for, and what sort of support services we can provide here?
Yeah, so this is a pretty new space in cancer care, the whole concept of integrative oncology, well-being, and how we best support people with cancer. Throughout the world, about a third of the patients we see have got breast cancer. Many of them are having curative treatment. And this is very similar in most integrative oncology services throughout the world. And so we've looked at what is it that our patient population presents with, what are their main concerns, and how do we best address them. So we know that it's a heterogeneous bunch of people, isn't it? Women with breast cancer, some are having surgery, only surgery after their chemotherapy, some will have chemotherapy, some will need hormone therapy as well. Some people will be living with triple negative disease or HER2 positive, hormone receptor negative cancer. And so each of those groups of people will be having different treatments and different concerns. But the top concerns for most women, particularly those having chemotherapy, and I'll take that group first, are sleep disturbances, nausea related to treatment, anxiety related to either the side effects of the treatment itself or the future, sleep, fatigue, and with that is coupled sleep disturbances, hot flushes, suddenly being thrown into menopause, and chemo-induced peripheral neuropathy. And so when we take those top concerns and we say, well, how do we address these in the best way possible? We look at what do we have in our toolbox to address those concerns. So let's just take the example of fatigue. And so cancer-related fatigue, and you know, I've missed out cognitive fog, I've missed out stress management. There is so much for this group of patients. We know that fatigue is something that is influenced by a whole lot of other factors. Are you not sleeping well? Are you suddenly getting hot flushes? Are you worried? Is it the treatment itself? Is it, there are other factors. Not everyone comes into breast cancer healthy. So what else is going on for that person? And we look at, first of all, screening to make sure, is there something that we can correct that will reduce your fatigue? And then what can we put into place based on the evidence? So we're looking at the evidence for exercise, in exercising from the time of diagnosis for breast cancer patients for managing fatigue, acupuncture. So we have a beautiful paper that was published in the Journal of Clinical Oncology, which is ASCO, which is the big American Society of Clinical Oncology, endorsed guidelines. And we look at what level of evidence do we have to recommend these things. So exercise, very high level of evidence. Massage in breast cancer patients, level B evidence, very high level of evidence to say that it actually helps people with their fatigue and their stress management and their sleep during breast cancer treatment. Similarly, acupuncture for both fatigue and for other symptoms related to breast cancer. And so we look at building this multimodal evidence-based approach to these common symptoms in breast cancer. So it's a really exciting space. I think the most important thing is meeting the person where they are. And I'm my background is in symptom management. I'm obsessed with identifying symptoms, symptom clusters. We know that all of these things, they don't occur in isolation. Where people have clusters of symptoms, we know that if people who are having AC chemotherapy, for example, about halfway through the treatment, they're going to go, oh my God, I can't do this anymore, I'm so tired. And then we say, okay, now it's time for paclitaxel. And after about 6 cycles of paclitaxel, they may be developing peripheral neuropathy. How do we catch that early and proactively manage that? And so we get what we can preempt what might happen for somebody and then develop a proactive program to empower people to move ahead and get through their treatment as easily as possible. So it's really about asking the questions using patient-reported outcome measures to get the patient's voice, identifying what's going on for them, using the evidence to build a really strong and dynamic and engaging program that fits that person's needs, and empowering people to continue that on into survivorship. So I see it as, really the approach that we ideally should be taking for all cancer patients, but I think most of the research has been done in the breast cancer patients. And the evidence really supports that, not every woman will proactively engage in these treatments. Some people will. Some people, it's just in their nature to go, yep, give it to me, I am going to engage. Some people have their own resources and say, I'm fine, I'll get through this. And then there are some women who you say, come on, let's work out how we can best help you and nurture you through your treatment. And so there's plenty to offer, and it's just working out how we best reach those people in the best way possible. Through education from the time of diagnosis with the surgeon on is ideally the best way forward.
Yeah, thank you, Judith. So I think what we've been hearing from Cindy, Kate, and Judith is really that we need to get a sense of who the patient is, what her needs are, where she's at, what her psychosocial environment is like, what sort of symptoms they might be having, what needs they need, and optimally address that. So it sounds really like quite an individualized approach, and I think that ties in nicely with one of the questions that we thought would be interesting to ask of Cindy. We're kind of wondering, can you discuss a little bit your thoughts on the impact on a person's sense of self-esteem and also body image, with a diagnosis like breast cancer, and how surgeons typically address this? I mean, does this influence the surgical approach, and if so, how?
It does influence the surgical approach, is the short answer. Because
and the long one?
The longer one is that, once again, all patients are different, and some are very practical. I have one very common thread is people coming to me saying, take them both off now. Mm-hmm. And that sounds like a really practical idea, but then I say, well, if I took them both off, would you want a reconstruction? And then there's this moment of pausing, and they're thinking, well, I don't even know what that involves. Then I say, if I say to you, it makes it much trickier to do your treatments if we have bilateral mastectomies and immediate reconstructions. Would you still want me to do that? And then we kind of go backtracking again. So my general approach is less is better than more at the beginning, because you can always go back and do more, but I can never go back and put a breast back.
Reattach it, yeah.
And what you find is that anxiety and fear drive these requests at the beginning. So and because we see it all the time, we can identify that. The patient doesn't know any better. The patient comes to you full of anxiety. It's their experience is the only experience that they know of. So when I say to them, let's stop for a minute because I've met, 100 women like you, and in 1 year, you'll be sitting back here, we'll be talking about something else, and I'm so glad you did not let me go ahead with that decision. And then for other people, it is absolutely the right decision. So, and yes, it does impact on your self-esteem, but in different ways. A small cut with a small divot in the breast can impact a woman significantly because for her breasts are really important. And then there are other women who have 2 flat scars on their breasts, and they're like, that's fine, I've got no problem with this at all. I'm not defined by my breasts. Once again, it's about reading the patient and trying to identify to what degree that cosmetic change will impact on their psychosocial state. And I agree with so many things that Judith said. The issues about identifying or trying to empower your patient early rather than late. So if I know somebody's going to need chemotherapy, they often get so fuddled when they come and see me, they can't even think of the right questions to ask. So for all the patients sitting out there, I think a really good question to say is, have I forgotten anything I should be asking? Or is there anything else I should have asked you? Something like that. Because sometimes your surgeon will think, well, actually, she forgot to ask me this. Or I should be telling her that. So one of the things that patients do ask me, which I think is a really awesome question, is, what can I do now for myself? Right now it's a waiting game. I've got to wait for my surgery or my chemotherapy or whatever. What else should I be doing to assist you and to assist myself? And there's a whole bunch of things. Exercise is a big one, right? If you smoke, don't.
Yes.
Alcohol, look, there's some data to say that small amounts of alcohol is reasonable. And sometimes I say to my patients, this is a really stressful time. If you feel like having that little 1 glass of wine at dinner tonight is going to help you, then maybe do go ahead, because our goal is not to make your life more miserable than it already is. But at the same time, don't do anything foolish that's going to impact on your health. So just things like exercise, improving your diet, even just saying these things, even though the patient knows them, the fact that they can go back and action them makes them take control of the whole situation. They've got to take control of something. So many things have been taken away from them.
Yeah, I think that's a really important point, and certainly one that we try to address too in the living room, is to empower patients to regain a sense of control and be doing something for themselves and for their health that supports the overall anti-cancer treatment as well. So
I give them another tip.
Yes.
Organize yourself. Really, really important. You'll see so many doctors.
Yeah.
So many appointments, and you'll forget when everything is, because chemo fog will come into it and all that kind of stuff. So find a friend or just organize yourself. And you know what? Sometimes we're cool with you recording a conversation if you.
Yeah.
I am anyway. I can't speak for other colleagues. I've got no problem with a patient asking my permission for a recorded conversation. And I understand that you're going to forget about 70% of the stuff that I tell you before you walk out of my room. So if you're alone, that's a completely reasonable thing to do.
And I will jump in there, Cindy, and say, as I score people's, memory disturbance and the cognitive fog, which we know is quite significant during breast cancer treatment, but also coupled with anxiety, just giving people a 1-pager of what I've said in this consult, key points, so they can refer back to that.
So Judith, can I ask, how do you do that 1-pager? Do you write it down as you go along in the consult and tailor it accordingly?
I do. In my medical records, as I'm sitting with somebody, I say, okay, we've talked about these things. Why don't we write something down so you've got a checklist on diet, on exercise, on what else on stress management, and on mind-body therapies, and what we can do and what we've said in the consult, so that you can look back at that and have a bit of a checklist. So I think that written, those key points are really important, but also going into the surgery, into the surgeon's office or the nurse's office with a list of, I have to remember these, to ask these things. I encourage my patients to do, because I think people get very anxious.
Yeah, they do, yeah. Often by the end of my consult, I pretty much have answered most of their questions, but I do give everybody a written information about the operation with all the bullet points of their possible side effects and an explanation of what they can expect in terms of post-operative recovery and things like that, because these are things that people just forget.
Yeah. Yeah.
Great. Well, that sounds like an excellent way of helping people remember the important points of a conversation. I'm just seeing we have 2 questions in the Q&A box. That's great. For everyone who didn't hear this at the beginning, we'll be having a chat here for the first about 45 minutes or so, and then I'd really like to encourage everyone who's listening in, if you do have any questions, please put them in the Q&A. If they're a question for one of our panelists, please maybe just add who you want that question asked of, and then we can hopefully address that in the last part of our webinar session today. Yes, I think I might quickly hand over to Kate again. I'm just wondering from a, from a perspective, your role as a nurse, what do you come across with patients in terms of self-esteem and body image? And I'm thinking that might be a little bit different to what patients talk to their doctors about. It may not be, I'm not sure, but I just wanted to get a sense of what your experience is with that.
Yeah, I think everyone is very different. And just like Cindy was saying, like some women, it comes down to how important your breasts are to you as a person. Some women are extremely attached to their breasts and really feel like the thought of them being scarred or removed, they feel like a great sense of loss. And you can't always pick which patient that's going to be. Like sometimes I'll see, quite an elderly woman come in and think, oh, she won't mind, but she's actually devastated. And then, a young woman who might have had her children, but she's still, quite young. It's just like, no, I don't need them anymore. I don't care. So I think it is, you can't always pick who's going to feel that that loss and that change in their body image. So you kind of have to be sensitive and expect it from anyone. But I think we're doing a lot more reconstruction these days. So there's not as much of taking off the whole breast and women walking around flat-chested. So I think that's definitely helping with body image and knowing that there are options to have the breast reconstructed, or different ways now of removing the lump without deforming the breast. So yeah, but everyone is totally different, and I think it's just coming to terms with their new breast, whether it's their new shaped breast or their new breast with an implant in it, or their belly tissue that's there. It's just a process, but I think it's also just reminding them, that we're doing this to save your life. So just always reminding, it is, although it's terrible, it's necessary, and this is what's going to allow you to go on and live for many years. So, yeah, but
Can I join in with Kate's thing about this is really about, for us surgeons, the cancer first and foremost.
Yeah.
Okay, we love it when we get a great cosmetic outcome, but ultimately my job is to rid you of your cancer.
Yeah, exactly. So always bringing it back to that point. You're not here because you wanted a boob job. You're here because of cancer. So of course we want to make it look as good as we can, but the treatment and saving you is the first and foremost. But yeah, you can never pick who's going to be more affected by the body image thing, but we just have to be sensitive to it and be there for support.
Okay. Thank you very much for that, Kate and Cindy. I think we might move on to another topic within breast cancer, and that's the fear of cancer recurrence. So once you've had the initial treatment, the initial diagnosis, the initial treatment, you've finished that successfully, and then you sort of move on into the survivorship phase. There's always this issue of potential recurrence. So Judith, can you maybe speak a little bit to that?
Yeah, so I think this is one of the main reasons that the main conversation that I have with women from the time of diagnosis, but also really in that survivorship space. So people are coming to the end of their treatment, and I'll often see women, I'll say, come back and see me near the end of your radiotherapy or during your radiotherapy, and we'll discuss where you can go to from here, how you can reduce recurrence, what diet changes are evidence informed, what we know that women with breast cancer use a lot of herbs and supplements, what's safe, what's not safe, what lifestyle changes you can make to reduce your recurrence risk, what the evidence is, and how you can deal with the stress and anxiety related to that fear of recurrence. And so that's quite a big topic when you think about it. And that's where there's this increasing growth of survivorship support programs for women after breast cancer. And I think it's really important. So if we just talk about diet, I noticed in the Q&A, one of the questions was, is there a particular diet recommended? And the first thing that's recommended is either the Mediterranean diet or just a really healthy, balanced diet full of fruits and vegetables, cruciferous vegetables, reducing unnecessary elements of your diet that you might be keen to reduce for other reasons, because you'll have multiple risk factors. So things like refined sugars and excess fat, making sure that now that you're entering, for many women entering menopause, that your risk factors for heart disease change as well. What's a healthy diet that encompasses the whole person, but also has been shown to be beneficial for breast cancer? So it's the plant-based diet and Mediterranean diet, lots of fatty fish, maybe some less red meat, less preservatives, a healthy diet that addresses the whole person. But also looking at the risk when people are going on to hormone therapy. So we know that it's not just fear of recurrence, it's living well. And we know that a lot of people put on weight with breast cancer during their chemotherapy and after onto hormone therapy. So making sure that they're on a balanced diet coupled with exercise to make sure that their weight is managed. Talk about the pros and cons of varying diets. So there's which diet, there are a lot of diets out there. There's intermittent fasting, there's the ketogenic diet, there's the alkalizing diet, but making sure that it's the right approach for that person with that cancer, and talking it through and working with the dietitians to make sure whatever people are doing, that it's balanced, that you're not depriving your body of the key materials that you need to stay well. And then looking at how you can live with the uncertainty that cancer may come back. And that's where mind-body practice and psycho-oncology are really important. So identifying people who really can benefit from talking about it with a one-to-one consult with a psycho-oncologist, but also recognizing a lot of people don't want to talk about it, and that's the role of yoga and yoga therapy and mind-body therapy, like mindfulness meditation or other meditation practices. And people say, but I can't meditate. And working out how we can assist people to really develop a stress management coping program to reduce that anxiety that keeps you up at night, that doesn't help you sleep, that means that your stress levels are higher. And so this is all interrelated, and mindfulness-based meditation is one of those key therapies that's really being looked at as the benefit of mindfulness or other meditation technique in managing stress. It's actually got level A evidence in the breast cancer guidelines. In integrative therapies, it's safe and helpful. And so looking at what you can do to reduce your stress and your fear of anxiety, what you can do with safe use of herbs and supplements. So I work with our pharmacists to make sure if someone brings a list of herbs that is often this long, is it safe during your treatment? Are there any interactions? Can it be beneficial? Can it be harmful? And we gave a talk before I did with one of the senior pharmacists on the safe use of herbs and supplements, looking at the pharmacokinetics, the pharmacodynamics. How does it interact with other drugs? You don't want to make your chemotherapy, for example, less beneficial or have worse toxicity. Is it safe during your surgery? Certain herbs and supplements shouldn't be taken that may thin your blood before or after a surgery, and similarly with radiotherapy and the antioxidants. So safe use of herbs and supplements, And then the biggest group are those women with triple negative breast cancer. They say, what can I do? You know, I'm not on hormone treatment. What else can I do to improve my chance of survival with this disease? And the role of immune modulating activity like good sleep and exercise and reducing stress and certain use of diet and supplements. And so this is a really big and important part of the ongoing care of women after a diagnosis of breast cancer, is that let's support you from the time of diagnosis and build a strategy that works with your lifestyle to stay well.
Thank you, Judith, for explaining that in detail. So it sounds like there's a lot of things you can do to help with remaining well and also managing your anxiety. Is there anything from a surgical perspective, Cindy, in terms of the fear of recurrence, how you approach that with patients?
Yeah, I'll try and answer some of the questions that have come up while we're doing this. The first thing I will say is that we have done a really bad job of addressing this as a surgical community. And part of the problem is that there is actually no good data on saying that somebody is cancer-free. Like I say to my patients, I'm never going to say you're never going to get your cancer again. You might get a new cancer in a remaining breast or some other part of your breast in the future, which is not related to this one, but your risk is higher if you've previously had a breast cancer. Or you might get a recurrence either locally in the breast or distant in the future to other parts of your body. It is a really terrifying thing for people, but there's no way of being sure who's going to get it. And there are no good tests for you to do on a regular basis to determine that you are going to be one of those people or determine whether your cancers come back early. So the problem is that there's no data to support routine scanning or routine blood tests for breast cancer in terms of trying to work out if somebody's recurred. And it's a really difficult conversation to have with people because they'll say to me, okay, well, it's like 2 years now, what happens now? And I can continue to do the mammograms and the ultrasounds for them, which, you know, may pick up a local recurrence early or new breast cancer early, but I can't control what happens in the rest of their body. And it's such a hard thing for them and for me to manage. There are scans that we can do if you have a symptom, but there's no data to support doing regular scanning for you. And the problem is that it comes with radiation risk, but also cost and anxiety. And anxiety is a really significant problem. Sometimes you'll get a tiny, what we call a false positive, that you can't actually action. You don't know what to do with it. So then you have to follow it up. It could be nothing. It could be a cyst on your liver, a small little scar in your lung, and we find it. And then you and I are both anxious about this for the next 6 months while we're waiting for a follow-up scan because it's not reasonable to biopsy this.
Yes.
So I would love to hear Judith's thoughts on how you manage that anxiety. So that's one thing. And then to address the question about being a survivor, I agree that saying that you're a survivor of breast cancer can be very empowering for some people, but also a little bit misleading for others. Because really, for me, breast cancer is a chronic illness, just like diabetes or heart disease. You're going to have to live with the fact that you had this diagnosis all the rest of your life. And you have to be vigilant. Because if you've had a previous cancer, it may recur again, or you may get a new one. That risk is very much lower if you've had a small, low-risk breast cancer that's been adequately treated, and obviously a little higher if you've got a more aggressive cancer, particularly if you're undertreated. So everybody is different, and it's not possible to give you a number exactly. But managing your approach to life, because the point of making people live longer so that they can enjoy their lives. And what we don't want is for them, I don't want to extend your life by this much, for you to have this much misery added on top of it. So we have to work together to find a good way of this post-treatment phase of managing it together.
Absolutely. Thank you, Cindy. So I think one of the comments here in the Q&A box was also generally the question, what type of support is useful after completion of treatment? I think Judith talked a little bit to that already, but I think really important is the statement, it is at this point that we suddenly feel like we're jumping off a cliff with no support or direction. So I think, yes, that's the thing we commonly see after active treatment, that people feel kind of, like jumping off a cliff. So that would be interesting to maybe.
I can understand that. And actually that's where Judith comes into it. I think those people are really well served by going to see somebody like Judith.
And I think and I will jump in here, I agree, I don't like the term survivor or survivorship, and we call our program Living Well with Cancer and Beyond, because I think it's really about how to empower people to live well. And we know that people who live well and engage regularly in checkups, either with and what I try and do is stagger my appointments with other people's appointments. So somebody is checking in, particularly people who are anxious about recurrence and may have a higher risk of recurrent disease than other people, that they check in regularly with one of their team over time. So they're not seeing everybody once a year, they're seeing a different person every 3 months, so that they're being monitored, and that often reduces that fear of recurrence because they're checking in. And so if they've got symptoms, they know that it's okay, they're going to be seeing somebody in a year or in 3 months, because we know that the oncologist might say, the medical oncologist might say, great, I'll see you in a year, and they go, oh my God, what else can I do? The Cancer Council's also developed programs like the Enrich program and support programs that really help engage women after cancer, and support programs are really helpful. I think the question of fear of recurrence, oh my God, how are they going to know that my disease has come back, is really hard and really challenging. And unlike other cancers where, we can easily monitor and we know what we're looking for, breast cancer is quite unique in that we really don't have the clear association between cancer markers and recurrence in people whose cancer markers were normal from the start and don't have metastatic disease. I think we've got different populations. I think the challenge is engaging people so that every ache and pain or new symptom doesn't make them fear they've got recurrent disease, and they feel comfortable with their general practitioner, their oncologist, their surgeon, or myself to come and talk about those new concerns rather than wait for an appointment many months later. So it's really about empowering people. Survivorship Programs is the title. I think we're all changing our names and calling it supportive care programs, living well after cancer programs, the Enrich program. There are different names, and I think everybody's trying to catch. There's the Thrive, there's the Five to Thrive podcast that some people are running. There's a lot of different ways of naming this concept, but survivorship is sort of that, is this a battle that we're in? It's not. It's just a new way of living and developing a resilience, and empowering people.
Thank you. We have a few questions here on specific symptoms. So I think one question I saw earlier was that was directed at Cindy. Is there any, from your perspective, any particular sort of red flag symptom that one needs to be watching out for?
I've actually put it into the answered box now. I've typed an answer to it. But essentially, it's anything that's not normal for you. But it's so hard because so many symptoms are just routine parts of aging. I've got sciatica since I had kids. That just happens. And you have to, I think, wait a little to be sure it's real. Maybe keep a diary of it so you know that it's real. Don't dwell too much on it, because if it's something that you're thinking about constantly, it is going to be real to you eventually. And if you're not sure, just come and talk to us. We will sort it out for you. We're not in the habit of turning you away for a routine scan just because we don't know what to do with some of the answers. If somebody's got a symptom, we will investigate that. It's just for the person who doesn't have any symptoms and is continuing on, quite well post-active treatment. Those are the people that probably don't need routine scanning, and we wouldn't go chasing that. If you've got a symptom, come to us. So generally it's things like unusual headaches, new cough or symptom. It's really hard in COVID times. Everybody who coughs gets a test now. Commonly breast cancer metastasizes to lungs, the liver, and to the bone, and very occasionally to the brain as well. So bony pain is often the most common thing that people will present with, a funny shoulder ache or commonly in the spine, it's in the midline. So it's not usually, say, it wouldn't happen here, for example. It's not a typical place. It might happen somewhere in your back, in your hips, in your neck, your shoulders. Those are the most typical things.
Okay, thank you, Cindy. We have some more symptom questions here, and I think that might be for Kate and Judith. So what are the best remedies for hot flushes and fatigue after treatment? And also along those lines, a comment here, Chris O'Brien Lighthouse offers complementary therapies to assist with treatment and surgery side effects, and the participant wishes all centers offered this, so thank you, we're glad to hear that. So the question is there, how many patients use it? Is there evidence for acupuncture to assist with symptoms of lymphedema, or is only massage useful? And what to do about joint pain from hormonal therapy? So I think hot flushes, fatigue, joint pain, lymphedema, what can we do?
Well, I'll jump in here. Lymphedema, we run a early lymphedema assessment program, and this is developing in many centres around Australia, where we proactively evaluate people who are at risk of developing lymphedema and then have a proactive approach to identifying early lymphedema and treating it with massage and exercise and self-massage and compression garments. There are some studies looking at acupuncture and lymphedema, but that's still in the work in process. The level of evidence isn't quite high enough yet. But when it comes to acupuncture for peripheral neuropathy, for hot flushes, the level of evidence is quite high. There's an interesting paper that just came out, I think, a few days ago, looking at genetic markers of who responds best to acupuncture for these symptoms. And are there certain people who are responders to acupuncture and others who aren't? So it's a really interesting space to look at. And we're running a study on taxane-induced peripheral neuropathy and acupuncture with one of our senior acupuncturists here. So there's a lot of growing evidence, and I can put in a link to a really good paper with the level of evidence and those.
Judith, can I say something about acupuncture with post-radiotherapy tenderness? It really does seem to work well for some of my patients. So after radiotherapy, a lot of people will get tenderness. I'm sorry, I'm going to have to show everybody. Usually down here and underneath here and on the inside. This is very typical. I usually get a phone call about, I don't know, 6 months post-radiotherapy with the patient freaking out about her chest wall tenderness. And the patients who go and have acupuncture for this find that it is really effective. So I don't know if there's any data on it, but it seems to be really good.
And there's a lot of data for pain syndromes, and actually ASCO and the Integrative Oncology Society are writing a guidance document on the evidence to support all these therapies and pain syndromes related to cancer, and that's coming out in the next year, I hope, few months maybe. So that's a very exciting space. But there is increasing evidence looking at these therapies, because we don't want people to be on long-term opioids or other painkillers. So we're looking at what else can you do outside of the box, because
what do you recommend for the hot flush? Diet, exercise really seems to make a difference.
So diet, exercise, acupuncture for some patients, but they need to have weekly sessions for 6 weeks. If they have non-hormone sensitive disease, so if they're triple negative disease, then you've got a little bit more flexibility as to how you manage hot flushes, including the possibility of sage and other safer herbs. But the main, and then you've got medications where everything else fails, like the SNRIs and SSRI, the antidepressant drugs that can be helpful. But it's really looking at exercise, acupuncture, and diet changes that may be helpful. But unfortunately, it's a hard one for some patients who really struggle. We know that about 25% of people really respond well to acupuncture for hot flushes, but that's only 25%.
The lucky 25, yes. Thank you, Judith. So Kate, did you have any other thoughts or comments? I think before we wrap up, yeah.
I think exercise is one that it pretty much helps all side effects of treatment. So that's one that that's the first thing I always recommend patients. I mean, it's for lymphedema, lowers risk, fatigue, also for peripheral neuropathy, it helps improve balance. So that's the key for me. And I'm not up with the latest research as much as Judith is, but I know that there is really high level of evidence for exercise. So that's definitely one that I promote. And of course, I send my patients to the living room for the lymphedema management as well. So for pre-op assessment, so that they've got a baseline and they get their education, and then follow-ups from there.
We have a question on what type of exercise is recommended, and does anybody want to address? There's actually quite a significant amount of exercise that's required to really make you well, and weight-bearing exercise.
Weight-bearing, yeah, it's moderate to high level, and I think it's at least like 3 or 4 times a week.
Yeah, so I think it's about 30 minutes to 45 minutes or something of activity. We're talking about at least 9 kilometers an hour if you're walking on a treadmill. For I think it's 5 times a week, is it, Judy?
That's 150 minutes of moderate exercise a week and 2 weight-bearing classes of about 30 minutes a week. As general for cancer, when you're looking at women with osteoporosis, then there's more weight bearing that's required. So our exercise physiologists just get them all dancing. Dancing for osteoporosis is a really positive way of jumping, because you need to jump for osteoporosis. So that's a really fun way to exercise, and but it's the weight work that's really important. And so it's looking at an exercise that suits you, and yoga comes into that as well as a moderate exercise, but also using your own body weight can be considered a weight-bearing exercise. So that's a good way to incorporate mind, body, weight-bearing, and the 150 minutes of moderate, or I think it's 70 minutes of intensive. So a good soccer game, for example, or rowing with the dragon rowers once they're back on board.
But in addition to that, you don't actually have to leave your home to do any of this stuff.
Absolutely.
You can do it in your lounge room in your knickers. It really doesn't matter. You've got a small mat, your own body weight, can of tomatoes if you want, and you can do stuff in your own living room. But it does require discipline, and I will acknowledge that being on hormonal blockade does make it all much harder, and it's so frustrating for these women. To be told that they have to lose weight, particularly when it's so much, then it becomes so much harder. Some of them might reach menopause, but then they've got this additional burden of having hormonal blockade on top of that. I don't have a solution for that. All I can say is life's not fair and you have to work harder.
And I think what we have been recommending through the Clinical Oncology Society of Australia and the Exercise Society, and this is also a global recommendation, that you get a personalised program developed for you by a physiotherapist or an exercise physiologist that develops a program for you that suits your needs. So if you've got really sore wrists, then you work out a different exercise program. Anything is possible, but you just need to work with somebody who has ideas and knowledge in the field.
Okay. Thank you very much. I think we've reached the end of our webinar. Thank you all for a very engaging and interesting discussion on all things boobs related, but not only. So thank you, Cindy. Thank you, Kate. Thanks, Judith. And before we go, I'd just like to flag that we're having another webinar, the last webinar of the year, which will happen on Friday, December the 4th, and it will be on the topic of sleep. So anyone who's interested, stay tuned. Thank you very much for joining us today, and I hope you have a lovely weekend.
And just to say that this will be, for those people that couldn't join us or those people who want to pass this on, this will be taped and available. And please share the link. So we know it's at an awkward time of the day, so there are some people that may be interested in this, that you would like to share the link to this webinar.
Thank you very much for having me.
Thanks for joining us, everybody.
Thank you. Bye-bye.
Bye, Anna. Bye-bye.